Testing, testing. Hi guys, welcome back. We are in module 14. I'm so excited. This is our last lecture week. I'm so proud of you guys. You made it this far. We have this week and then next week is our exam and we are done. We got through another semester. I'm so proud of you. You must be so proud of yourselves. This week we are getting into urgent care visits and specialty exams. We have about 35 slides to get through, so I will try to get through them quickly. I will be posting another PowerPoint within this module by the middle of this week to coincide with your study guide, which has already been posted. So please focus on your study guide and the review quizzes, the quiz reviews, as well as your previous lectures and the lecture that I'm going to post this midweek this week, specifically focused on the study guide. All right, guys, so here we go. So the first thing I wanted to just do was go through the review of the assigned reading topics for each chapter. I just always like to pinpoint certain things that I want you to look through. The textbook goes through basically a review of systems and the most common presenting complaints you will be presented with in an urgent care setting. The important thing to be able to differentiate is what is treatable in urgent care and versus what requires a higher level of care. So, for example, an emergency department or a trauma center. Now, that being said, the likelihood is for the majority of people who are in an emergent situation, they are going to be calling 911 or going directly to the emergency room. But that being said, some people are coming in with things that are, kind of on the cusp of being emergent versus an emergency. So you have to really help figure out, what needs to be dealt with immediately versus what you can deal with in the urgent care facility / environment. Because remember, in an urgent care facility, you are limited to what resources you have. I've been in urgent care facilities that don't even have a code card, which to me is absolutely ridiculous, but that's the way it is. So you always have to know when you're working in a facility or any kind of center or clinic or any of these places, what resources you have available to you in case of an emergency and what you don't have available to you. So you know that you have to be very proactive when certain people or certain conditions walk through the door. You already know, what, before I even think about it, I'm just going to call 911 because I already know I can see the writing on the wall. There's a lot of red flags here. Let me just go ahead and be proactive and call 911 because I already know I'm going to need backup in this situation. So you always have to be on guard for that sort of situation in terms of urgent care complaints. So in chapter 72, we got into common urgent care complaints like pulmonary complaints. They got into the different type of walk-in clinics and they talk about what you do have available to you. And again, they kind of go through a review of systems, EENT, musculoskeletal, the neuro system. Please make sure you review box 72.2 for the red flags for headache diagnoses, because remember, there are differentials for headache diagnoses that you need to make sure you're aware of. The number one thing, if they tell you it's the worst headache they've ever had, that is a red flag. You need to send them to the emergency room immediately, 911. They get into GI complaints, dermatology complaints, and wound care, cardiovascular complaints, as well as genitourinary. In chapter 73, we talk about common injuries such as wound and lacerations. Please focus on the history in those presentations of those particular types of diagnoses. You want to look at your advanced assessment on page 1212. Make sure you're reviewing how it is you would assess a patient who comes in with a wound or a laceration and how you would deal with it. Please look at therapeutic procedure abscess drainage. That is something you will come in contact with, not only in urgent care, but in any primary care practice. When I was doing wound care consulting, obviously I dealt with abscesses. It is something you will likely come across that you need to know how to handle. You want to make sure you're reviewing suturing techniques and the materials used in suturing, because there are all different types. And when you become proficient at suturing, you will be probably a little picky about which materials and what type of suturing you're doing, because whatever you become comfortable with and what works for you and your patient, of course. Box 73.1, you're going to want to review patient education and discharge instructions in terms of wounds and lacerations. Definitely review patient education in terms of animal and human bites. Burns, you want to review burn injuries, the types of injuries and their characteristics. The rule of nines, make sure you understand how to estimate a total body area affected by a burn based on the rule of nines. Make sure you review that. We'll go into that in one of my slides. Drugs commonly prescribed for burns, please review that on page 1228. And of course, patient education information, specifically regarding SPF and education to prevent burns. So remember, you want an SPF of at least 15, which will help prevent burns. But make sure you review that table 73.2. We got into head traumas in terms of your readings. Make sure you're able to differentiate between contusions versus fractures and hematomas. You want to review the layers of the meninges, the cranial circulation, and the location of the hematomas. I do have a slide in that to review as well. Please familiarize yourself with the Glasgow Coma Scale and how to assess and calculate the scoring of a concussion. You also want to provide a patient education related to head traumas, so make sure you review that. That should be reviewed not only with your patient, but your caregivers and parents as well. Musculoskeletal trauma, you want to make sure you're reading the advanced assessment in 73.3 and reviewing how to read an extremity x-ray, as well as what price therapy means and how you educate your patient on performing this type of therapy. We got into pneumothorax and hemothorax. Please review box 73.3 for tension pneumothorax, as well as patient education. Foreign body obstructions are also common injuries that you're presented with in urgent care. You need to make sure you're reviewing general management and patient education. Toxic exposures in chapter 74, we get into poisoning, common toxidromes and clinical manifestations, as well as patient education. Please make sure you review those three things. They talked about arthropods bites and stings and reaction grading. So make sure you know how to grade a reaction for documentation purposes. Look on page 1258, as well as patient education regarding bites and stings. Chapter 75, we got into environmental exposure, specifically heat-related illnesses, cold-related illnesses. We're talking about hypothermia as well as frostbite. Please review your types of heat-related illnesses. Within your module, you have an education tool from the CDC regarding heat-related illnesses and how they present and what to look for. Review your patient education. Review your cold-related illnesses, your hypothermia, your degrees of hypothermia on page 1268, as well as the patient education you be providing, as well as frostbite and the degrees of injury included in frostbite and their patient education as well on page 1270. We got into our practice guidelines where you're reviewing foreign body removal from the nose. Again, it's never too much practice to continually review the neurological examination. You do want to have that really, really down pat before you walk into an urgent care center and start working, because it's a tool and an examination you're going to be using quite frequently. Same thing with tick removal, page 824. Please review how to remove a tick. It is something you will see much more up in Connecticut and New York than you will by me in Florida, but definitely make sure you review how to remove them. And in terms of your advanced practice procedures, we reviewed in our procedure book abscesses, again, bites, ants, bees, and wasps, bites from cats, dogs, and humans, burns and debridement on page 27. Again, they review the rule of nines and the depth of burn injury within your Coiler book, so make sure you review it in there, as well as your primary care textbook. They talk about skin closure on page 58, insertion and suture selection, as well as suture removal in your advanced practice procedures. Again, I had you review tick removal and removal again of foreign body from the ear and nose, as well as gastric lavage, which we use a lot in trying to get people who have ingested some kind of poisonous substance. We do a gastric lavage to help have them get rid of everything out of their stomach. So in terms of defining urgent care, one of this pie chart here gives you a really clear kind of example of the different diagnoses that you're presented with in urgent care. So the definition of urgent care varies, but most experts agree that it is the provision of outpatient medical care for illness or injuries requiring immediate or prompt attention. Urgent care may be provided by a patient's primary care provider in the office setting or by providers in a walk in health clinic. These clinics are designed specifically to conveniently accommodate urgent care needs without the cost of an emergency department visit. The purpose of walk-in clinics is to provide convenient quality care at a fraction of the cost of an emergency department visit. So it's much cheaper within the healthcare system to utilize urgent care as opposed to an ED. There are several types of walk-in clinics, allowing patients the convenience of unscheduled visits. These clinic models include walk-in primary care, on-site, retail, urgent care, freestanding emergency departments, and traditional emergency departments. If you wanted to review these different types of clinics, please look at box 72.1 in your textbook to review further the differences between them. Nurse practitioners play an important role as clinicians in these clinics. 2/3 of urgent care centers are staffed with non-physician clinics, and more than one half do not have a physician on site. Many are staffed solely by NPs. Urgent care nurse practitioners make about 5% more than the national average of all NPs. The information presented in this pie chart reflects data from a survey of an advanced practice registered nurse practice involving 155 visits at a suburban urgent care center in South Florida. This discussion of these chief complaints includes epidemiology and triage information intended to help the practitioner decide which patients can be treated within an urgent care setting and which patients should be referred to other practitioners. So again, guys, it's part of our role to make sure that these patients are appropriately being managed in the appropriate setting. So if they come into urgent care and we don't feel they belong there, they need a higher skilled level of care, then that's what we make sure we put in place, and we make the referrals and consultations accordingly. So some of the other common urgent care complaints could include pulmonary complaints, ear, nose, and throat complaints, as well as musculoskeletal complaints. For non-traumatic musculoskeletal pain, lower back pain is probably the number one condition that clinicians manage each year. Lower back pain may be due to occupational factors, poor body mechanics, or obesity. Keep in mind, lower back pain is specifically covered in Chapter 53 if you wanted to review that. Osteoarthritis or degenerative joint disease occurs in at least some joints in most persons older than 40. According to the Arthritis Foundation, osteoarthritis is the most common chronic condition of the joints, affecting approximately 27 million Americans. A person with osteoarthritis will typically awaken with stiffness and a cracking sound in the joints, and as the day progresses, the pain and stiffness will gradually lessen with movement. There may be mild swelling, and toward the end of the day, the pain may worsen. Osteoarthritis is the main reason for joint replacements. Please review arthritis in Chapter 55 if you needed more in-depth information about that. Now, that was non-traumatic musculoskeletal pain versus traumatic musculoskeletal pain. So traumatic musculoskeletal pain includes your sprains, which can occur during common activities or due to falling, twisting, or being hit and forcing the body out of alignment. A sprain is caused by a stretched or torn ligament, and strains occur frequently in athletes and are more common in sports requiring repetitive motion, such as football, hockey, baseball, or tennis. The big thing in terms of triaging sprains and strains is that they have similar symptoms of pain and inflammation with possible bruising at the affected area. So although the pain is subjective, the clinician needs to use assessment techniques to really confirm the diagnosis. Now, in terms of fractures, a bone fracture may be either caused by trauma, force, or stress, or a disease such as osteoporosis or cancer, which is pathological. Fractures are prevalent usually until the early 20s, and then they level off around age 60 when the incidence increases. Fractures related to violence are 10 times higher in African Americans. So just keep that in mind if you have an African American patient, especially if they're coming in with frequent fractures. That's when you're concerned about any kind of violence or domestic violence in the household. Fractures need to be diagnosed on clinical exam, or they require or may require an X-ray or CT or an MRI. Fractures require immobilizations, which will range from casts or braces to surgery involving plate screws, nails, or external fixators, depending on the situation. Urgent care practitioners may apply casts or braces depending on the level of swelling and refer patients requiring surgery to an orthopedic surgeon or the emergency department. Complications of fractures include malunion, osteomyelitis, and actual bone death or avascular necrosis. Other than a simple break, such as a green stick fracture that may be treated with a cast in the urgent care setting, patient with more involved bone fractures, just as a comminuted or impacted fracture, should be referred to acute care. So just make sure you understand the difference in terms of your fractures and how they present. So we also get into our neurological and psychological complaints. Remember, headaches, there are 150 diagnostic headache categories, and the most common types of headaches are tension type headaches and migraines. Others include caffeine withdrawal headaches, hunger headaches, or pathological headaches, such as those caused by an aneurysm, giant cell arteriolitis, or hypertension. So we've gotten into headaches, the causes of, and their clinical presentations already, but this is just going to be like a focused review of the most important things to remember in terms of patients presenting in urgent care. So when taking a history of a patient with a headache, just remember to assess the signs and symptoms that may indicate certain red flag diagnosis that require immediate emergency care. Make sure you review box 72.2. If any of those emergency signs and symptoms are present, then further evaluation should be done, including an ESR rate, like an erythrocyte sedimentation rate, lumbar puncture, and neuroimaging. Other than patients with suspected temporal arteriolitis, these patients should be sent up to the ER for further diagnosis. If you wanted to review headaches and their presentation, please look at Chapter 9. In terms of headaches, you always got to remember red flag would be a patient saying they are having the worst headache of their life. That when they say that, we're concerned about a central nervous system infection or an intracranial hemorrhage. Headaches that are triggered by coitus, a cough, or exertion, we're concerned about CNS lesions or subarachnoid hemorrhage. Again, if we had any change in our mental status or level of consciousness, again, we're worried about a CNS infection, intracerebral bleed, or CNS lesion. Anything over the age of 50, when it comes to headaches, the first thing you need to consider is temporal arteriolitis. GI complaints include diarrhea. Now remember, acute diarrhea is the passage of 6 or more stools daily without improvement for 3 or more days. So you gotta have 6 or more stools every day for 3 days or more in order for it to be actually diagnosed as acute diarrhea. Acute diarrhea may be caused by infections, non-infection conditions, and medications. Their infections include bacterial, viral, parasitic, and foodborne illnesses, as well as traveler's diarrhea and infectious gastroenteritis. Most causes of acute diarrhea in adults are self-limiting and of infectious etiology. You always want a detailed history, specifically in the case of diarrhea, to determine the cause. Patients with a bacterial infection may have additional symptoms such as fever, tenesmus, or bloody stools. A person with a viral infection may present with nausea and vomiting with an onset 24 to 48 hours after possible exposure, whereas a foodborne illness usually experiences symptoms onset 2 to 7 hours after possible exposure. So just keep that in mind, guys. If it's a viral infection, it's usually going to start a little bit later versus a foodborne illness. It's pretty much going to start pretty quickly right after exposure, within 2 to 7 hours. If the diarrhea lasts more than 7 days, The clinician should suspect a parasitic infection. Testing may not be necessary, but guidelines are available for the selection of the appropriate lab testing. Don't forget your CDC website, guys. They have so many resources, especially when it comes to people who are traveling and presenting with a particular set of symptoms. So, in terms of animal bites, an animal bite is a bite to humans from dogs, cats, or other animals, including other humans. In most cases, bites result in puncture wounds, possible lacerations, and in some cases, crash injuries. All bites, regardless of the source, are considered to be contaminated wounds and have a substantial risk for infection. If the bite was inflicted by a wild animal or occurred in an unprovoked attack by a domestic animal, the practitioner should ask the patient to have the animal that inflicted the bite evaluated for rabies. We need to have these animals evaluated for rabies. If they get their rabies shot, have they ever been exposed to rabies? Were they bit by another animal? You need to know this. The patient or his family should contact the local health department and consult with an animal control officer about the patterns of rabies among animals in the local areas. Because keep in mind, guys, that changes. It fluctuates based on the season, based on the animal um, population within the area. So there's a lot of factors involved with, possible rabies exposure. Definitely make sure you educate patients or individuals that about the importance of not petting or feeding unfamiliar or wild animals. I used to have a patient and his wife who would feed these squirrels right outside their back door every day. And then one day, I'm in there treating him for a surgical wound. He's post-op, a couple weeks, and all of a sudden he's getting this massive infection. He has a massive infection, and I really couldn't help but consider and wonder if part of the issue was the wife was doing the wound care and she at the same time was feeding a wild animal. And I couldn't help but wonder if there was a germ relation in that household because I don't ever remember seeing her wash her hands after she was feeding these animals. Their little feed that she bought at the supermarket. Anyway, just be very, very careful with wild animals. The germs and bacteria they harbor are very dangerous, specifically for anybody who's immunocompromised or has any sort of open wounds. Patients should be reminded to elevate injured extremities to prevent swelling and to return for follow-up if there's any signs of fever, redness, or swelling, especially given the subsequent risk of infection. The client should definitely instruct patients to watch for any kind of red streaks, increased warmth at the site, increasing pain, foul odor, or increasing drainage from the bite wound, all of which should trigger the patient to seek urgent assessment in the clinic or ED. Burns, according to the 2016 fact sheet of the American Burn Association, on average of 486,000 burn injuries receive medical treatment in the US every year, with 3,275 of those fire related and smoke inhalation deaths, and 220 from other sources. So there's a lot of statistics about the risk of burns and how it affects our population. Keep in mind major burns. A patient with a major burn should be immediately transported to a burn center or an emergency department. A major burn is defined as follows: partial thickness burn with greater than 25% of TBSA or total body surface area in a person 10 to 15 years of age or greater than 20% of TBSA in a child younger than 10 years of age or an adult older than 50. All right. So just make sure you differentiate your burns and how they present. Initial management of a patient with a major burn should really include maintaining the patient's airway, breathing, and circulation. So remember, guys, your CPR rules, your ABCs: airway, breathing, circulation. That's the first thing you need to make sure is okay. If there's time before transportation to the emergency department or the burn center, the patient's clothing should be removed if further damage to the skin can be avoided. Jewelry should also be removed and secured in a safe place. The patient should be placed and covered with a clean, warm sheet and clean blankets with overhead warmers if available. No other wound is typically required until the patient reaches the ED or the burn center. The survival rate for a burn injury is 96.8%, with the majority of burn injuries being treated in the outpatient setting. For that reason, it's so important for you guys to understand the pathophysiology of the burn, as well as the skills to treat the burns. So the bottom line is the very basics of understanding wounds is just understanding how to estimate the total surface area of a burn on your skin, on a body. So just make sure you understand the rule of nine. So like if I said both of your anterior legs were burned, um, you would already know because it's anterior, both legs equals nine. 9 plus 9 is that's 18% of our body has superficial burns on it. Okay, so just keep that in mind because you will probably have questions on your exam from that. In terms of patient information, in terms of burn prevention, always make sure you remind your patients to wear sunburn, especially in sunny areas or on travel. Always wear sunscreen when outdoors on a sunny day. You want an SPF of at least 15, which will block most harmful UV radiation. For the average adult, the recommended dose is 1 ounce per application. So you want to reapply every 2 hours after being in the water or after exercising or sweating. And of course, use broad spectrum sunscreens that contain active ingredients so that we get at least 85% of our UVA and UVB rays covered. So here's just the diagrams from your book in terms of wound lacerations and sutures. Keep in mind the wound healing process involves many processes that occur simultaneously. So we have our injury phase, our inflammatory phase, our epithelialization phase, and our remodeling phase. You really want to review those phases because you may have questions on that on the exam. Patients with lacerations frequently present to urgent care for urgent care treatment. Suturing is the most common technique for closing the edges of a laceration. However, staples are faster but are more likely to result in scarring if they're left in too long. And believe me, they get left in too long because patients leave facilities or leave the hospital and these suture lines are forgotten. And then all of a sudden they end up in a long-term care facility and 3 months later they still have the staples in. So you do want to make sure you educate your patients as they're leaving. You need to get these out within a certain amount of time. Give them a date frame of when they need to have them removed, as well as a resource as to where they should go to have them removed. Okay. Patients with lacerations frequently present to urgent care. Suturing is the most common technique. Staples are faster, but we want to make sure that we don't leave them in too long, as well as don't use them on the face, neck, hands, or feet. Those are no good for the staples. Okay. Wound infection is always a concern with laceration management, and the clinician should be especially alert for this complication, specifically in patients with diabetes, right? If there's any wound contamination, if the laceration is greater than 5 centimeters, or if the laceration is on a lower extremity. Okay, those are the high risk wounds on a diabetic patient. So here's your suture techniques. We have a buried suture, a running continuous suture, and an interrupted suture, as well as some wound closer strips. Please review this in chapter 73. Next common injury we got into was head trauma. Really important to review the Glasgow-Coma scale. And remembering the Glasgow-Coma scale, you're assessing 3 areas: eye-opening, motor response, and verbal response. Okay, and based on the score tells us what the level of their mental status is. Okay, 3 to 8 is severe, and the higher we go, the more mild it becomes. All right, so we actually want a higher score in this particular coma scale. Keep in mind types of head trauma that may be encountered in primary care include cerebral contusions, concussions, skull fracture, and epidural or subdural hematomas. In contrast, subarachnoid hemorrhage typically results from the spontaneous rupture of the intracranial aneurysms in about greater than 80% of cases. So that's a lot of cases, rather than traumatic etiology. So a lot of these could result from subarachnoid hemorrhages, these head traumas. The majority of head trauma patients will need to be transported to the nearest emergency department for emergent evaluation and care. In terms of management of your musculoskeletal trauma complaints or common injuries, remember we have strain, sprain, fracture. Please make sure you differentiate those. Management of the patient with musculoskeletal trauma initially consists of price therapy, as described later in this section. However, you may need an x-ray to identify the damage to the joint or bony structures. So patients can normally be seen immediately in an outpatient setting with radiographic capabilities. That's probably why this patient came to urgent care. But the patient may choose to see his or her primary care practitioner for follow-up, which I always advise. Otherwise, the patient should proceed directly to the emergency department for diagnostic studies or further intervention is needed. Keep in mind your price therapy in your musculoskeletal trauma. What does PRICE stand for? It's a beautiful acronym to make sure you remember. PRICE being protection, R being rest, I being ice, C for compression, and E for elevation. Protection of the injury involves both prevention and protection. Protection may refer to the preventing of injury from occurring or making it less severe by wearing protective gear such as helmets, wrist pads, knee pads, a back brace, just being super conscientious, using a cushion in your car to give you lumbar support. All these different factors and modalities can help prevent further injury as well as further pain. Now, when it comes to educating your patients on rest, like what does rest mean? Like you have to define this for patients because a lot of patients don't know how to rest. So rest means no use of the affected limb or joint for minor injuries or sprains for 1 to 2 days, followed by slowly increasing the use of the limb as tolerated by the patient. If the patient's activity being performed causes pain to the injury site, the level of activity needs to be reduced to levels that do not cause pain. However, mild discomfort after activity is considered normal during the rehab phase, but we don't want it to be so severe that it's preventing them from actually even doing their therapy or making them terrified of not even wanting to do their therapy. Generally speaking, the amount of limb rest needed depends on the severity of the injury. So again, when we're looking at musculoskeletal trauma, please focus on the history. Find out when, find out how, find out for how long, find out what makes it better, what makes it worse, what aggravates it. You know what I mean? Ask those questions, guys. Okay, so here's the layers of the meninges, cranial circulation, and location of hematomas, just to get an anatomical view and just to remind you of what you're kind of mentally thinking about as we talk about these things. Again, looking at your Glasgow Coma Scale. Remember, when you're scoring, you're really looking at their best motor response, best verbal response, and eye-opening responses. The best response you could get at a Glasgow Coma Scale is a 15. That's the best score you can get. You're 100% fine. Versus your comatose client, you're about an 8 or less, versus somebody who's in a vegetative state or totally unresponsive is at a 3 or below. These are just a few tips in terms of things you need to make sure you remember for your basilar skull fracture, specifically where you have your battle sign and your raccoon eyes, as well as typical alterations in cranial nerve function. And they give you examples here, which is part of your cranial nerve exam. So the Glasgow Coma Scale can be used rapidly to evaluate the level of consciousness, and it establishes a baseline neurological status in those 3 areas of eye-opening, motor response, and verbal response. Function in each of these 3 areas is rated on a progressive scale as noted, with a maximum score 15 representing normal neurological function. So you always want to make sure that you're also looking for any signs of increased intracranial pressure. And those early signs include headache, nausea, vomiting, amnesia, altered level of consciousness, changes in speech, drowsiness, agitation, restlessness, and or loss of judgment. If they have any of those symptoms, we're getting them straight to the emergency department. More common injuries include pneumothorax, which refers to the abnormal presence of air in the potential space between the parietal and visceral pleura and thorax. A hemothorax refers to the abdominal presence of blood in the same region. For this potential space to become occupied by air or blood, there must be an injury to one of the pleurae. A pneumothorax is described as closed if the chest wall is intact, or open if the chest is violated and communicates with the atmosphere. We also reviewed foreign body obstructions, again, ear, nose, throat, vaginal, and rectal, which we'll get into. Here is a beautiful comparison of a normal chest x-ray versus what you're going to see on a simple pneumothorax. So just familiarize yourself with this, guys. It's not something that's going to really change that significantly from one patient to the next. If they have it, they have it, and you'll see it. You'll see it. All right. So just keep practicing by looking at your patient's charts and seeing what radiology images you can bring up to start really getting practice and saying, okay, I understand why Mrs. Lee was having so much pain in her lung because she has a fractured rib or whatever it is. You know what I mean? Just continually open your mind to the idea that there's so much more for you to learn than just what you're learning in your class and in your clinicals. There's just still so much to go. So definitely open yourself to any opportunity you're available to. So in terms of patient education with a pneumothorax and a hemothorax, if you have a patient who's been diagnosed with a spontaneous pneumothorax, they should be counseled that about 23 to 30% of patients who've had this will have it again. They have a reoccurrence at some point. So you have to make sure you explain to them the signs and symptoms to watch for, which includes dyspnea, persistent cough, and chest pain. All patients should be, once they've experienced this, they should be re-educated on again and say, listen, not to scare you, but the likelihood is there is a high chance that this could happen again. And for that reason, I'm going to tell you what you need to do and how you need to do it if that does come up. All right. Give them control over the situation. The clinician should definitely consider consulting a respiratory therapist before discharge to initiate incentive spirometry and teaching for home use, as well as an aid in recurrence prevention. We got into foreign body removal. So here we have a foreign body removal from an ear. Foreign bodies in the auditory canal, it's all based on the patient's signs and symptoms and the orifice involved, as well as the clinical signs of the foreign body. So you got to get, again, the history, talk to the patient, talk to the family member about what exactly is the foreign body, quote unquote. That would help, in terms of the substance, the type of material it is. Is it plastic? Is it something that's jelly and pliable? You know what I mean? Like those are the things we need to know because we have to get it out. So we have to figure out a way. These are especially common in children, and foreign bodies can be vegetative, inanimate, or animate objects. Foreign bodies in the ear are usually asymptomatic unless they're left in the ear for a prolonged period of time and an infection develops. An insect or a piece of cotton caught in the ear may cause equilibrium problems, dizziness, tinnitus, and diminished hearing on the affected side. So again, the clinician should obtain a complete history to see if there's possibly more than one foreign body in the orifice. The practitioner should definitely assess both ears to obtain a comprehensive view. And it's important to ensure that there are no perforations of the tympanic membrane before trying to remove the foreign body. Some patients can have a foreign body in the ear for such a long period that their earwax will eventually mask the foreign body. So you want to get that out as soon as you can, guys. In terms of toxic exposures, poisons encompass a wide variety of toxic compounds, including pesticides, drug overdoses, carbon monoxide, household chemicals, bleach, and venom from biting or stinging organisms such as spiders, snakes, and scorpions. So they kind of mix up the poisoning and the bites and stings kind of in the same slides because they do coincide. Something's biting you and injecting you with poison, you're going to want to know about it. So when we have a suspected poisoning, the priority of the primary care nurse practitioner is to treat the immediate medical condition. And although psychiatric evaluation becomes secondary to emergency treatment, a mental health eval and treatment is nonetheless an important and necessary component when treating the poisoned patient, given the strong association of poisonings with internal ingestion, self-harm, depression, and most importantly, suicide. All right. So a lot of the times you have to really be careful that you question whether or not the suicide or the toxic exposure you're being presented with wasn't precipitated by a suicidal moment. Those are the things you want to definitely keep in tune with and make sure you're filtering out and basically kind of ruling out in terms of differential diagnoses. You want to make sure that your patient's ABCs are assessed in terms of emergency management with poisoning. Remember, airway, breathing, circulation, so important. As soon as you see or realize that this patient's poisoned, you want to activate emergency medical services to get the patient transferred to the nearest emergency department. While obviously your role is to continually and concurrently monitor the patient's individual respiratory and cardiovascular status to make sure that they don't code. You also are going to need to contact your local poison control center to make sure you're getting the up-to-date, most perfect, and best options in terms of treatment recommendations and antidotes for whatever toxic exposure they were exposed to. Please definitely review Table 74.1 for management principles of common poisonings. So in terms of toxic exposures, we also got into bites and stings. Arthropod bites and stings. Arthropods are members of Arthropoda, a large phylum of animal life characterized by an external body support structure known as an exoskeleton, which involves and includes lobsters, crabs, as well as mites, ticks, spiders, and insects. So in the next slide, I'll show you just some varying clinical presentations of bites. The majority of your disorders caused by bites and stings of arthropods are from spider bites, bees, wasps, and ant stings. Sometimes the caterpillars with their little spiny irritations, they can cause some like little disease infections. Excuse me, guys. And in terms of the venoms produced by these insects and other arthropods, they can be classified according to their effects. So you're going to want to review what these different effects from the venom are. So we have vesiculating toxins, neurotoxins, cytotoxic and hemolytic toxins, and hemorrhagic toxins. Okay. So hemorrhagic toxins would include lice, fleas, ticks, mites, and true bugs, and biting flies, because all of them prevent blood from clotting. So if the bug toxin affects each little pathophysiology in the body differently. So make sure you review that. Here is a beautiful diagram of the varying insect bites and how they would present. Remember, bed bugs come in clusters. Bees are usually one-time thing. And keep in mind, when a yellow jacket stings you, it usually dies. So that's they're not always out there to sting you, but if you're there and it happens, it happens. We've got our nice mosquito bite, our tick bite with that raised red bull rash. And then we have a nice spider bite. Spider bites are no joke, guys. You need to know what kind of spider the patient was bitten by, and you need to take action very quickly. I had to go in for a spider bite right on my forehead into an urgent care facility, and they wanted to turn me around and send me directly to the emergency room because as I was driving there, my face became so swollen, my eyes started to swell shut. So obviously I needed an emergency treatment because otherwise they were concerned I was going to go into anaphylaxis. However, I drove myself to the urgent care facility. So in order for me to get to the emergency department, they would have had to call an ambulance. And by the time all that would have been done, I really would have run out of time in terms of dealing with this because they were concerned I was going to go into an anaphylactic reaction because my face was so swollen. So the PA actually came out and cut the bite where it was on my forehead open. Apparently it needed to be drained. She drained it. A ton of stuff came out of it. It all happened in a matter of hours. Like I went to bed, woke up, my forehead was a little puffy, looked like I had a bite, no big deal. And then all of a sudden, within an hour, my face was really swollen. And I was like, oh, I think I need to deal with this. So, the reaction to these things happens very quickly and it's very severe. That bite, despite being drained and despite me being on antibiotics 3 times a day for a month. A month. Still, it did not go down. The swelling in my face did not go down for a month. My family was relentless. I was on actually a family reunion at the time, and unfortunately, my family is brutal, and they called me Cyclops the entire time because I was so swollen. But it was a good laugh for everybody. But it was a brutal thing, and it just reminded me of the importance of just making sure I remind you guys to be very conscientious about figuring out, looking at doing a really thorough history and dealing with whatever you're presented with quickly to prevent it from getting turning into something much more severe. Okay, environmental exposures also included heat-related illnesses, which includes your heat rash, your heat cramps, syncope, exhaustion, stroke. So heat-related illnesses, it's important to understand that they are actually a continuum of conditions that range from mild to severe. Most heat-related deaths are usually preventable, guys. Um, so you just want to make sure you do a thorough history and just really make sure you're reviewing the risk factors, which include anything from fainting episodes, vasodilation, peripheral pooling of blood, volume deficit, sluggish vasomotor tone, syncope. Those are all things that we're leading into an emergency situation. Keep in mind, heat exhaustion occurs when the body overheats and it's unable to maintain its normal core temperature. When you are, presented with heat exhaustion, some of the symptoms the patient may present with include thirst, heavy sweating, tachycardia, dizziness, nausea, vomiting, and weakness. It's usually caused by like strenuous work in hot or humid environments. Your treatment would incorporate rest as well as moving to a cooler environment, removal of clothing that prevents evaporative cooling, and of course, making sure the patient is hydrated. So, in terms of heat stroke, make sure you understand that it's characterized by a core body temperature of 104 degrees or higher, mental confusion, and more severe clinical manifestations that typically go beyond the symptoms of heat exhaustion. It can cause damage to multiple organ systems as well as cause a breakdown of tissue, muscle tissue, also known as rhabdomyolysis, and the mortality may be as high as 10%. If your patient is presenting to you in a primary care setting or even an urgent care setting and they have heat stroke, you should be calling 911 while you're maintaining the patient's respiratory and cardiovascular status, to make sure that they are evaluated and supported until the EMTs get there. Just keep in mind the CDC has their own recommendations and what to look for and what to do in terms of heat related illnesses. Please review your module. I did upload these recommendations into your module so you could download this PDF specifically so you can actually read it. This is kind of small and a little blurry. So I wanted to make sure that you look at that. In terms of education about heat related illnesses, you should make sure it's just part of a health maintenance type education, especially in regard to younger patients as well as your older patients and the elderly. The primary care practitioner should warn patients of the risk of leaving children in cars unattended, as well as older adults should be cautioned about the increased risk of heat related illnesses, especially if they have medical conditions or are taking medications that increase the risk of heat related illnesses. Athletes should be drinking more fluids and try to exercise, during the coolest part of the day. Environmental exposures also include hypothermia, which is a medical emergency that obviously can threaten life and limb and is defined by a core temperature of less than 95 degrees or 35 degrees Celsius. If it's not treated promptly and accurately, the diagnosis carries a high mortality rate and the patient's outcome depends on the underlying medical conditions and the duration of exposure to the elements. Okay, so remember there are different grades of hypothermia. We have mild, moderate, and severe. So you want to make sure that you're getting, hypothermia is a medical emergency. So you want to get these patients transported to the nearest hospital as quickly as possible. However, But, while you're waiting and you're making sure that they're being managed until they get to the hospital, you want to make sure you're including prevention of heat loss, initiation of rewarming, and the avoidance of dysrhythmias. Wet clothing should be removed and replaced with warm blankets while drying the skin to avoid shivering, which depletes glycogen stores. Emergent management consists of assessing airway, affirming breathing, and monitoring circulation with the initiation of basic life support measures as appropriate. These patients, especially if they are in severe hypothermia, you're watching them to make sure they don't go into cardiac arrest, because if they do, that's when you need to start CPR. Most of the management includes, supportive care with warm IV fluids, cardiac monitoring, a lot of vital sign checking very frequently, supplemental oxygen if they need, repeating your electrolytes, APGs, and ECGs as needed. Um, you want to make sure that the clinician who's doing this is making sure that the acid-base balance, in terms of their pathophysiological changes, is balanced very, very closely and well, to make sure that they don't have an emergency situation. We're almost done, guys. So here is just a slide to kind of differentiate mild hypothermia versus severe hypothermia. You and make sure when you're discharging these patients from the ED or in hospital care, the primary care nurse practitioner needs to consider the patient's age, psychological and medical status, and his or her living situation to plan like appropriate follow-up care. Like if this patient is homeless, we need to make sure that we get them resources, and a wide social network has to be engaged to prevent the reoccurrence of the hypothermia. You want to try to get these patients connected with a case manager to really give them guidance and all the support they need in the community to get them back to where they need to be and to prevent any infection. You may even have to go as far as determining if the patient is homeless, if they actually have shelter, especially if it's during the winter months, or whether the patient even has enough adequate clothing, a winter coat, or even adequate food availability to help promote the healing process. If not, you need to make appropriate referrals as indicated. Other like basic stuff you also want to do in terms of education with patients is make sure to educate your younger patients, especially your extremists, your young teenage guys who are in their 20s, especially if they're really into sports and extreme, living, whatever. You just want to make sure you kind of give them the heads up, like, hey, make sure you avoid alcohol and any use of drugs, or any overexertion during extremely cold temperatures or extremely hot for that matter. You just have to tell them to be careful, because sometimes they lose their ability to make good judgment when they're drinking or doing drugs. So it can actually put them at higher risk for hypo and hyperthermia. Another environmental exposure you may see is frostbite. And this is freezing on an exposed area. It's usually the ears, cheeks, nose, fingers, or toes. And just you need to make sure that you're aware that there are 4 degrees of injury: first, second, third, and fourth, which I will get into in the next slide. Okay. Frostbite is also a medical emergency, again, because of the potential for extensive tissue necrosis and loss of a limb. All right. Nobody wants to lose a limb, whether it's the tip of a finger or a leg. Okay, we have to avoid that at all costs, whatever we can do. So if the patient is presenting to the primary care setting and they have frostbite, the area of frostbite should be rewarmed, and hot liquids such as coffee, tea, or broth should be administered. Okay, the basis of treatment for frostbite is to reverse the pathological effects of the ice crystal formation, the vasoconstriction, and the release of inflammatory mediators. That is the damage that is being caused by the frostbite. So our goal is to kind of reverse it. Treatment should not be started if there is a possibility of refreezing. So if it is suspected that the patient has second to fourth degree frostbite, hospitalization should be considered. Okay, again, guys, you can only handle so much in the urgent and primary care settings. Do not hesitate. If you're uncertain and you're not quite sure, do yourself a favor, do your patient a favor, and get them to the emergency room so that a higher level of expertise and care can be provided to prevent any kind of limb loss. I mean, we don't want our patients to have to go through that. It's horrible. And here in our next slide, here's your stages of frostbite as just a review. So stage 1, there's really no frostbite. You have frost nip in stage 2. See how red and angry his fingertips are. In stage 3, we have superficial frostbite with blisters. And then in stage 4, we have deep frostbite, and you'll see actual necrosis on your fingertips. So your patient's education, they should be taught to watch for any signs of infection, to take all their medications as prescribed, and to use extreme care regarding any further exposure to cold. They should also make sure to do preventative measures, like not go outside for long periods of time. Of course, they need to wear their hats, earmuffs, mittens, and dress in layers, stay out of wet clothing, dress in natural materials like cotton or wool. We want to avoid caffeine or tobacco or alcohol when going outdoors in the cold, because again, these substances can leave the skin more prone to thermal injury. Also, we want to make sure we're checking the skin every 12 to 20 minutes for signs of frostbite when exposed to cold environments. Okay, specialty exams, guys. So the 2 specialty exams I wanted to focus in on in this lecture are your DOT CDL exams and your veteran CMP exams, DPQ exam, disability questionnaire. So the other big exam that is a specialty exam is your sports physicals. We already did that, guys. We already got into that. We already went through that. You already know the key factors in that. The Department of Transportation, in terms of your DOT exams, requires that truck drivers get something called a commercial driver's license. In order to be eligible for a commercial driver's license to drive a Class A or drive your Class B trucks, which are your light trucks, your charter buses, your school buses, your metro buses, all of those, Class A, Class B, require a CDL license, a commercial driver's license. So you get these truckers who come into urgent care, primary care, who need a physical that's specifically called a DOT physical, or the Department of Transportation. And it's required for people who drive these commercial vehicles. And it's to make sure that the people who are driving commercial motor vehicles are physically, mentally, and emotionally fit. The Federal Motor Carrier Safety Administration, or the FMCSA, requires them for the safety of the public. So who needs a DOT physical? You will need a DOT physical or Department of Transportation physical if you drive a vehicle designed to carry more than 15 people, so that's your bus, are paid to drive a vehicle designed to carry more than 8 people, that's your light, school bus or metro, even smaller. You carry any hazardous material in your vehicle that requires your vehicle to have a place card. Or you drive a vehicle on an interstate with a gross combination weight rating or gross vehicle weight rating or gross combination of over 10,000 pounds. So those are your giant tractor trailer trucks. So the DOT physical consists of your medical history. You're asking them all about their medical history, if they've had any surgery. Of course, you're doing a comprehensive review of if they're taking any meds, any prescription meds, any over-the-counter meds. You review any health problems they've ever had. You talk about their tobacco, alcohol, or illegal substances use, if they've ever failed a drug test, if they've ever been dependent on illegal substances, or any symptoms they're currently having. Okay, I'm going to show you in the next few slides like a focused body system requirement of what the typical CDL driver is required in order to get his CDL license. The other big specialty exam we talk about and that we have in our world that you're going to maybe come across as a job position is the Veterans Compensations and Pensions exam. It's called the CMP exam. And these CMP exams are done intermittently depending on what the veteran is presenting with. And they are done through disability questionnaires, or they're called DBQ exams. Okay, so what exactly is this? Veterans come in when a veteran decides that they are putting in for a disability claim based around some kind of disability that they experienced while they were in service. So if they experienced any kind of back injury or any kind of problem that they suddenly developed while they were in service, they can put in a disability claim that they were injured during their service time. And then we have to do these DBQ exams to see if it's accurate, if this disability actually occurred during service, was exacerbated during service, or required care during service. And if any of those things come into play, you as the practitioner have to do the total physical exam as well as do a thorough social history and medical history review. And you have to kind of decide if you think that it really did occur during service and that the patient and the veteran should be compensated. So there's quite a bit of I would say, it's called a disability questionnaire, and that's basically the exam form you fill out as the nurse practitioner. And they have a DBQ for every body system. So if the veteran's coming in and saying that he injured his back during service because of all of the physical training and the amount of gear he had to carry, and he jumped into a hole one day, whatever it is, that will be specifically to musculoskeletal DBQ exam. Or if they said that they had a traumatic brain injury because of a IED that went off near them, and they had a concussion and it's led to tinnitus since then, and now they're going to claim that. Now we have a neurological DBQ exam that we would do. They have specific DBQ exams for each body system depending on the presenting complaint. So based on the complaint, you will get that DBQ exam when that particular veteran comes in. It's all extremely filtered and censored by the VA, guys. So even if you take a job like this, which a lot of nurse practitioners do take these CMP exam jobs because they're kind of a side gig for a lot of NPs as just an extra source of income, because you can kind of do it at your leisure. You can kind of give and take your schedule. And, most of the DBQ exams are now outsourced by the VA. So they actually hire external contractors to do these exams as opposed to having somebody within the VA doing them and possibly having kind of not an ulterior motive, but just it gives the veteran a little bit more of a clear leeway so they're not having any tainted views when these exams are being done. So if you have an outside contractor as opposed to somebody within the VA, you're hopeful that they're a little more discriminatory towards the veteran. I actually really enjoyed doing these exams and working with the veterans. I found it extremely fulfilling, much more than I thought I would. I actually did it full time for a short period of time before I, had to relocate. Otherwise, I would have probably kept doing it for quite a while. I enjoyed doing the DBQ exams, and I'm going to show you one of the tools. In the CMP exams, we actually use one specific tool called a goniometer, which you probably won't hear about in any other specialty besides these particular exams, because I didn't. Most of the time, this tool is more used by physical therapists. Really, what a goniometer is used is to measure the range of motion in degrees of joints for either active or passive joint range. So if a patient is coming in or a veteran is coming in saying they have knee damage, for instance, from some kind of injury during service, what we do is upon the first assessment, we measure their range of motion of their knee and how far they can measure, move that joint in, out, abduct, adduction, we measure it in all sorts of particular measurements. And based on those baseline measurements, we use those measurements periodically throughout the veteran's life to continually reassess, okay, is the joint functioning getting worse? Is it staying the same? Is it getting better? And based on these measurements, we can kind of give a good, thorough physical assessment for the DBQ information to say to the VA, hey, this veteran's joint mobility is declining, and it's probably because of the injury he sustained while he was in service, and now it's continually getting worse just with basic wear and tear on life. But because it's getting worse, his functional ability to perform, to work, to do whatever he needs to do is declining. So therefore, does the veteran, is he eligible for more compensation because now he can't work as much because he has such limited range of motion on his knee? So that's how you kind of have to work it. And that's how it kind of works when it comes to any joint, whether it's knees, back. We use the goniometer a lot for measurements in these particular exams. And in terms of your DOT physical requirements, these are the particular by review of system what they're looking for specifically that would probably keep them from being cleared to get their CDL license. So vision is very important. Obviously, they're driving a semi-tractor trailer. They need to have adequate vision. If we saw that their blood pressure was up, any signs of substance abuse or tremors, these are all concerns that we would need to do further workups to make sure they're appropriate to be cleared for this particular license. We worry about our truck drivers because they're very sedentary. They don't have exactly the best access to quality food and healthy food. So there's a lot of health issues that come with our truck drivers that we really need to address before we're clearing them for their CDL license. So please make sure you do a lot of education as well as follow up for these patients to make sure that they don't end up in some emergent situation. All right, guys, that's pretty much it for this week. Next week is your final exam. This module will include a posted study guide with the PowerPoint coinciding with it. I'll get it in probably by Wednesday. I'm sorry for the delay on that. I'm just starting a new clinical contract, so I'm working long days. So I'm just trying to make sure I get all of this material in for you, that it's thorough and really helpful so that you do really well on your final. But definitely review that study guide, create your own study guide based on that study guide, review your lectures, review your quizzes, your quiz reviews. And just so you know, it's a 50-question exam, multiple choice with 2 short answers. All right, guys, if you had any questions or you had any concerns, please just call me or email me to set up a meet, and we will definitely do that. I hope you have a great week. Good luck, guys. I'm so proud of you. It's been such a great semester, and I hope you all do great. I'm sure you will. Thank you, and have a great week.